So I wanted to come off the video that I did some time ago looking at upper GI bleeding, and I wanted this video to be based on esophageal varices. Grab your piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. In this video today, we're going to be looking at esophageal varices. It'll be much more of a focus looking at acute variceal bleeds as compared to those that are chronic patients that we're going to be managing on the ward once we stabilize them. I will do the management of chronic esophageal varices in another video, but I think I'll focus much more on the acute phase here. So before I actually go into the details of the lecture, I just want to give an example to actually set the precedence of this particular video. And I know a lot of you complained about the slides having a lot of words on them, so I made sure that I can actually reduct this one to as minimal words as possible, and I explain more of the concepts so that you can actually follow the video very well. So suppose you're actually headed into town and you're coming from, let's say, Chopstone, and you're using Great East Road, and let's say that's one of the major roads and the quickest way to get into town, and you find a blockade on your way to town. So you have two options. You can either try and use an alternative route, or you could go back home. So now, if you use an alternative route, everyone who's actually following your decision to use the alternative route will make sure that those other routes are congested. Traffic will be slow, and no one will be able to go through the main route. That's a similar thing that is happening in esophageal varices. So before we actually go into any details, I just want to have a look at it, a little bit about the anatomy, especially the blood supply. Remember that your blood is going to be coming from your left ventricle, being pumped into the aorta, to the head and the rest of the body. And this blood is supposed to be draining back through the venous system. Now, in terms of the intestines, you have the mesenteric veins, which are going to be draining blood. So here we have your superior mesenteric vein, and you have your inferior mesenteric vein. As you can see, your inferior mesenteric vein here is going to be receiving some tributaries from the splenic vein, and then you also have your left gastric vein over there. And then, of course, this is going to be joining together with your superior mesenteric vein, and eventually is going to be forming what is known as the portal vein. So this is what's going to be draining blood from the GIT and the spleen towards the liver. And remember that this blood that is being drained, remember that the purpose of GIT is for digestion of food. And of course, once the food has been digested, it's supposed to be absorbed and taken to the liver for detoxification and further metabolism of this particular food. Then eventually, once in the liver, it's going to be then passed through the hepatic veins into the inferior vena cava, getting into the systemic circulation. Now, if you have a blockade here in the liver, it means this blood that is coming from the superior mesenteric artery, this blood that's coming from the inferior mesenteric artery, this blood that's coming from the spleen, from the left gastric vein, is going to backflow. There's going to be congestion in these organs. The spleen is going to enlarge. There's going to be splenomegaly, which is what is common in cirrhosis, in patients that have cirrhosis. There's going to be congestion that's going to be there in these vessels, and ultimately increase in hydrostatic pressures. There's going to be transudation of fluid from these particular vessels. So that's what's happening in the patient that has esophageal varices. And remember that in this patient with esophageal varices, because now this blood can't flow through the liver, it will take alternative routes. And these alternative routes are going to be submucosal vessels, for example, that are found in the esophagus. So once these vessels begin to dilate, then we call this as esophageal varices. They could potentially rupture. So dilated submucosal vessels that are often due to portal hypertension is what we refer to as the esophageal varices. Now, remember that the gradient in pressures, if you compare the pressure of the portal vein versus the pressure in the inferior vena cava and even the hepatic veins, you get a pressure gradient that is ranging from 2 to 6 millimeters of mercury. Now, if the pressure is greater than 10 to 12 millimeters of mercury, you call that a significant portal hypertension. So these are patients that are at risk of developing the esophageal varices. These are patients that are at risk of bleeding from these esophageal varices. And remember that this type of bleeding from these esophageal varices is an upper GI type of bleeding. Remember that in terms of the division, where you're going to be making the division, there's a ligament of Treitz which separates what's proximal to the ligament of Treitz is what's known as the upper GI bleeding. What is distal is known as lower GI bleeding. We went into details of differentiating clinically, though there's a bit of a fine line in that, but how you may differentiate, for example, someone with an upper GI bleeding that may come in with melena, which is this dark tarry stool. So remember that the reason why they're having this melena is because they're bleeding, and these red blood cells are made up of the proteins, are made up of carbs, are made up of lipids, which are going to be broken down in the blood in the GIT by those enzymes that are part of the GIT. Such that when the gets to the end, the stool is going to be darkened. Then if it's lower GI bleeding, often they present with frank blood, but that's not a rule that is set in stone or a rule that is correct all the time, because in some patients, for example, those that have upper GI bleeding that is quite massive, you may actually even pass frank blood on the stool. So it's not a rule that is always set in stone. There are some exceptions to that rule. And remember that most of these varices are going to be occurring in the distal 5 centimeters of the esophagus. Most of these varices are going to be due to portal hypertension, a large majority of them. 50% of them will actually have cirrhosis. 50% of the patients that actually develop this bleeding esophageal varices will spontaneously stop, and 60% of them will actually have a risk of rebleeding within 6 weeks. So 15% in hospital mortality with treatment. It's a bit much higher if they don't get treatment. Then other causes may include things like portal hypertensive gastropathy, you have your gastric antrovascular ectasia, you have your gastric varices, and even intestinal varices. Now, remember that when your patient comes in with bleeding, and they're bleeding from the GIT, you're going to do an endoscopy, an esophageal gastroduodenoscopy, which is beneficial because it has 3 things. It's number 1, diagnostic. So it will help you make a diagnosis of esophageal varices, because remember that not all patients that have cirrhosis and come in with GI bleeding is equals to varices. Don't have that knee-jerk response, because some patients could have non-variceal bleeds. About 20% of the patients could have non-variceal bleeds. So you may use an endoscopy to actually differentiate those non-variceal bleeds. Then number 2, it is therapeutic. It's going to help you now manage this patient. You're going to perform banding, for example. You can perform sclerotherapy, for example, or you inject a sclerosing agent into those vessels, and this is actually going to help to stop the bleeding in most of the cases. And it's prognostic. So it's diagnostic, it's therapeutic, and it's prognostic. Prognostic in the fact that it can give you an idea of how likely this patient is going to have a rebleed. Because remember, we said 60% of those patients will have rebleed in about 6 weeks. And generally, on endoscopy, the size of the varice will denote the risk of rebleeding. The bigger the varices, the greater the risk. The presence at endoscopy of a red whale markings, for example, these are longitudinal dilated venules on the varice suffix. And then even the adherent clot that you're going to see, sorry, I'm confusing with, my bad, I'm confusing with peptic ulcer disease. But anyways, the presence of an actively bleeding vessel. Also, the severity of the liver disease. Remember, severity of liver disease is going to be marked by what is known as a Child-Pugh score. And this is a scoring parameter that uses 5 parameters. It's going to be using your bilirubin levels. It's going to be using your INR. It's going to be using presence of ascites. It's going to be using your presence of hepatic encephalopathy to actually grade your patients. The minimum score that you can actually get is 5. The maximum score you can get is 15. So this Child-Pugh score grades people and puts them into different classes, class A, class B, and class C. And the class A will have a survival of about 1 year, survival of about 100%. So after 1 year, 100% of your patients in class A will still be alive. While it's your class, as you go to the higher classes, for example, class C, you're a significantly lower percentage. About 40% of them will be alive. I'll show you the Child-Pugh score very shortly in the next slide. Then active alcohol abuse also will increase the risk of rebleeding. So this is the Child-Pugh score. So as you can see, you have total bilirubin, serum albumin, INR, ascites, even hepatic encephalopathy. So as you can see, the parameters are self-explanatory. You look at the 1 point 2 points if they have the following parameters, 3 points if you have the following parameters. And you can see when you add up the score of everything, 5 to 6 is class A, 7 to 9 is class B, 10 to 15 is class C. 100% survival after 1 year with class A, 45% survival after 1 year with class C, and 80% with class B. Now, one thing that I just want to explain is INR, which is a concept that some of you may not really know. So international normalized ratio is just simply prothrombin time, your prothrombin time compared to the control prothrombin time of that particular lab. The reason why we do this is if you actually get the prothrombin time of a particular patient and you do it at that particular instance, for example, you get a value of 16, then you get the blood again of the same patient and you repeat the lab, you find a different value. You get again at a different time, you repeat, you find a different value. Because of this wide variation in the value, we actually want to standardize it. So we actually get the patient's prothrombin time, we compare it to the prothrombin time of the control of that particular lab, and you get a specific ratio. So the higher the ratio, it means the greater your prothrombin time. It means that your blood takes a long time to clot. So it means that you have a greater risk of bleeding. The lower the international normalized ratio, it means that your blood takes a very quick time to clot, so the higher risk of you forming blood clots, the higher risk of thrombi. And remember, when you're giving anticoagulants, for example, in your DVT, you're aiming for an INR of about 2 to 3. So those that have less than 1.7, 1.71 to 2.3, 2 points greater than 2.3, you give them 3 points. So that's the Child-Pugh score. I'll talk about it more in details when we look at chronic liver disease. I want to start doing the liver topics very shortly. So in terms of clinical features, remember these are patients that are going to come in with painless bleeding. And that's what actually is going to be quite scary for the patient, because they'll be vomiting large amounts of blood, sometimes even with clots, this bright red blood with clots, and it won't have any pain, which is quite disturbing. They may have some other symptoms that may not be necessarily related to the esophageal varices per se, but may be related to, for example, the alcoholic gastritis or with the withdrawal. So they may have retching, they may have dyspepsia. The varices are a bit different from the Mallory-Weiss tears and even the Boerhaave syndrome, because those are going to present with painful bleeding. So remember that your varices are not going to be causing things like dyspepsia, dysphagia, or retching. Then they may come in with features of shock if you have severe vomiting. So they'll come in with altered mental state. They'll come in with a poor capillary refill time. They'll come in with cold extremities and cold and clammy skin. They'll come in with poor skin turgor. They'll come in with reduced urine output. They'll come in with a low BP and a low MAP. And this is a patient that is actually getting into shock. These are patients that you must resuscitate, because if you don't, they're going to go into organ failure and eventually they're going to die. So 20% of your patients, like I say, that have COD are going to develop GI bleeding, and it's not going to even be related to any varices or bleeding from the varices, which is why the endoscopy is very important and must be done within 12 hours for the emergency and within 24 hours for those that are not so urgent. So within 12 to 24 hours, your endoscopy must be done for these patients. The investigations are rather similar to what we order for in patients that have upper GI bleeding. So you want to do a full blood count for these patients. Remember, if this is a blood loss that they have had the first time, they don't have any history of chronic bleeding in the past, your hemoglobin is going to be normal. Reason being, if someone bleeds right now, remember that your body has to replace whatever has been lost. So it has to replace the red blood cells, it has to replace the plasma, it has to replace the white blood cells and the platelets, of course. Replacement of red blood cell. Remember that the synthesis of red blood cell from the pluripotent hematopoietic stem cell up until the reticulocyte stage takes about 5 days. Then from reticulocyte stage to mature red blood cells, 1 to 2 days. So it's a total of 7 days. And then plasma can be replaced much quicker. Within hours, it's actually replaced because it's mostly constituting of water. Majority of it is water. So now when someone bleeds initially and they come to the hospital, they have lost both blood, they have lost plasma. You get their HP is going to be normal. But after a few days, when that plasma has been replaced and those red blood cells are yet to be replaced, and then you check the HP, you realize that the HP will be low. So if someone coming in acute bleeding with a variceal bleed and you get the HP and it's normal, still we should be remaining vigilant with that particular patient, because they may actually not be showing you the true picture. But But if they've had bleeding for some time, for example, chronic or subacute type of bleeding, they'll tend to have anemia, a type of anemia that's known as a microcytic anemia. Then you also want to do your urea, electrolytes, creatinine, and your ABGs. What's quite important here to remember is the urea. So remember that they're bleeding, so there's risk of them actually having renal failure. But at the same time, those red blood cells that are actually entering into the gastrointestinal system are actually being digested by the gastrointestinal system. So this means that they are breaking down some of these components and they're being metabolized by the liver. And this is going to result in elevation of the urea. So it doesn't mean that urea being elevated is equals to kidney injury. That's the point that I want to make here. So it means that sometimes if someone has a normal creatinine, urea is elevated, history of bleeding, it means that that bleeding is severe. But if urea and creatinine are both elevated, it could be that perhaps, yes, they do have bleeding that is there, but this patient may have gone into shock. They may have some renal dysfunction. You also want to get your liver enzymes for chronic liver disease, your PT, APTT, and INR, which I already explained, cross-match them and transfuse them with blood. If you're not so sure if this is an esophageal virus, get your H. pylori stool testing, because maybe this could be a bleeding also. Perform an endoscopy. Remember, endoscopy is both therapeutic, diagnostic, and prognostic. It must be done within 12 hours of admission. So in terms of management, what is our acute management? Remember, this is an emergency, and all emergencies are going to be managed by your ABCs first. So your airway and your breathing, very important. These patients are at risk of aspiration. So often you want to ensure that you insert an NGT for these patients. Keep them nil per oral. Do not feed these patients. For the patients that have low GCS, for example, a GCS less than 8, make sure that you intubate your patients. Take them to ICU. So you're going to involve the critical care team quite early, involve the endoscopy and GI units quite early, involve hematology and the blood bank quite early over these patients. So you want to push in an NGT, and if the GCS is low, if they're not oxygenated quite well, they're not ventilating quite well, you want to intubate your patients to actually even protect your airway. You want to give them oxygen via a face mask, 100% oxygen via a face mask. And what is more important here is remember that they're bleeding, they're losing their oxygen carrying capacity, they're losing their red blood cells. So even if your patients actually have normal saturations, put them on oxygen because it helps these patients. Then with your circulation, you want to insert your large bore cannulae, and you're going to be drawing your blood. Your 2 large bore cannulae, you draw your bloods for your investigations, you draw your bloods for your cross-match. Make sure you also insert a Foley's catheter to monitor the urine output. You monitor the vitals closely. This must be done if you are well-staffed, you can even do it every 30 minutes. If possible, to actually connect the patient to a monitor, a cardiac monitor, even much better. Then you want to actually continue following up your patients, monitoring them at least every hour. Do your ABGs, do your urea and creatinine regularly, 4 to 6 hours. Then you want to start your fluids. So remember, your patients may come in and they're in shock. You give them fluids. So if they're in shock, you treat them with IV fluids. You can give them a bolus of normal saline, a bolus of Ringer's lactate. So you can give them a bolus of about 1 liter, sometimes even up to 2 liters of a bolus. So you can let the first 500 run quite quickly over 15 to 20 or even 30 minutes. Then again repeat, and then you're checking the BPs. Now what's quite important here is, again, you want your BPs to be at least borderline low. You don't want your BPs to be low because the organs will be hypoperfused. Again, you don't want your BPs to be quite high because you're going to increase the venous pressures, you're going to increase the risk of rebleeding. So you want your BPs to be actually borderline low. You resuscitate with your normal saline, you also resuscitate with your Ringer's lactate as you're waiting for blood to transfuse this particular patient. Now, again, in terms of transfusion, remember you can transfuse your whole blood, your red blood cells, your packed cells. You could transfuse your platelets. You could transfuse your fresh frozen plasma. It's not always that we transfuse your platelets. It's not always that we transfuse fresh frozen plasma. What you must remember is that often these patients that are chronic liver disease patients often have a balance between procoagulant. They have a new balance, what we call a new balance, a newfound balance in their body between the procoagulants and the anticoagulants, such that if you actually were to transfuse them with this FFP, for example, or cryoprecipitate, or other components of plasma, minus them actually having an underlying coagulopathy, you're actually putting them at risk, number one, of thrombotic events. So you're putting them at risk of portal thrombosis. You're putting them at risk of DVT. So it means that they're not routinely recommended if the patients don't have a proven coagulopathy. Then, of course, you're also increasing the portal pressures, increasing the risk of them having a bleed. But if their platelet count is less than 50,000, you can actually transfuse them. Or if they have a known impaired function, for example, in the presence of uremia or aspirin, you want to also transfuse them with your platelets or give them some desmopressin. Remember, if they are taking any anticoagulants, those must be stopped. So if you're taking an aspirin, clopidogrel, for whatever reason, it must be stopped. Heparin, your DOACs, even your NOACs, your direct-acting oral anticoagulants, those must be stopped. If the prothrombin time is increased and the INR is greater than 1.5, give them some FFP. Like I said, FFP is not routinely given. So some clinical pearls to actually keep in mind. Remember, you want to keep your BPs borderline low. I think I already explained this. The higher the BP, the greater the risk of them rebleeding. Then you want to avoid over-transfusion of these patients, because if you increase the blood volume, you're increasing the central and even the portal venous pressures, increasing the risk of rebleeding. INR does not reflect accurately the advanced liver disease. Like I said, there's a new balance that is there. And most patients with advanced liver disease will have coagulopathies either due to thrombocytopenia, deficiencies in the liver-derived clotting factors like those that are dependent on vitamin K, like 2, 7, 9, and 10, and deficiency in fibrinogen, which is factor 1. And remember, like I already mentioned, in COD, they often have this new balance. And then in terms of the recombinant activated factor 7, prothrombin complex concentrates, even cryoprecipitates, most research has actually shown that they have generally no efficacy. They haven't demonstrated any efficacy. They haven't demonstrated any increase in, or rather reduction in mortality rates, so they're not routinely recommended, unless if the patient really needs them, if they have the deficiency in these specific factors. Then platelet transfusion, like I said, for those less than 50,000, there are some other literature that actually quote a value lower than this, about 20,000. And after you resuscitate your patients, you want to actually get an ultrasound with Doppler so that you can rule out any portal vein thrombosis. They are at risk of portal vein thrombosis. And remember, your ABCs, your airway, breathing, we've taken care of that. C for circulation, D for drugs, disability and drugs. So there are important drugs that you can give in these particular patients. But before I come to the drugs, the one that you shouldn't forget is glucose. Always check their random blood glucose. Because remember, this is a patient that may have been vomiting. This is a patient with chronic liver disease. This is a patient that may be hypoglycemic. So make sure that if they're hypoglycemic, you bolus them with your dextrose so that you keep their sugars in an acceptable range. In terms of the medications that we give, the drugs that we give, antibiotic prophylaxis. So remember that 50% of these patients that are actually admitted with chronic liver disease are at high risk of severe bacterial infections. So they're at high risk of them developing SBP, or spontaneous bacterial peritonitis. Of course, most of the patients that are coming in with this routine tapping, these paracentesis, are at risk of having this pneumonias, they're at risk of having UTIs. Most of the infections are going to be coming from the GIT, so you want to cover them on third-generation cephalosporin. Ceftriaxone is a very common drug that's used, 1 gram per day. You can give it for 5 to 7 days. And remember that this administration of antibiotic prophylaxis has been shown to actually reduce the risk of serious infection by about 10 to 20%, and actually has also been shown to reduce the mortality rates of patients in the hospital, especially those with a Child-Pugh score of C, or rather Child-Pugh class C. Then you also want to give some vasoactive drugs. Remember what is happening here. These patients have portal hypertension. The gradient across the portal vein as well as the inferior vena cava is greater than 10 to 12 millimeters of mercury. So you want to cause vasodilatation of those portal veins and even the splanchnic veins to reduce the pressure gradient so that you reduce the risk of them, the blood going through these collaterals, and reduce the risk of esophageal bleeding from the varices. Then to do this, we often give 2 drugs, octreotide and somatostatin. We're not so sure how they work, but what we know is that they actually reduce the splanchnic and the hepatic blood flow, as well as the blood portal pressure in the cirrhosis patients. So with octreotide, we give 50 micrograms IV bolus, then 50 micrograms per hour. With somatostatin, 25 micrograms per hour. And these are actually quite effective. They don't improve mortality rates. They have no effects on mortality, but they are quite effective, such that 80% of your patients, it will actually be able to stop the bleed. But it's even much more effective if you combine them with endoscopy with a therapeutic measure. For example, If you combine octreotide with endoscopy plus banding, or octreotide with endoscopy plus sclerotherapy, or somatostatin with endoscopy but plus either ligation or banding, or rather banding, ligation, or sclerotherapy, it has been shown that combined modalities are much more superior to individual modalities alone. So for your patients that actually come in with upper GI bleeding and those that have advanced liver disease, we often should start them on octreotide or somatostatin, and you should continue this for 3 to 5 days if the varices are confirmed by endoscopy. If you've done the endoscopy and it's not varices, then there's no need to continue this medication and you can stop. Then another drug is telepressin, which is a synthetic vasopressin. You give about 1 to 2 milligrams IV every 4 hours. This one causes a significant reduction in the portal and the variceal pressures while it's preserving the renal function. So remember that most of these are causing vasodilation, so they may actually worsen renal function, but telepressin actually preserves renal function. So this can be used intravenously every 6 hours for 3 days. For those patients, it has been approved by the FDA for treatment of hepatorenal syndrome with acute decline in renal function, especially in those patients that are not responding to 2 days of albumin infusion. Remember that we want to avoid these vasoactive drugs in patients with coronary vascular disease, in patients with cerebrovascular disease, in patients with peripheral vascular disease for obvious reasons. Other medications to consider: vitamin K. Only give this if your patients have an abnormal prothrombin time. There is no rule of routine vitamin K administration in patients with esophageal varices, but if they do fit the bill, you can give them 10 milligrams IV. In terms of lactulose, for the patients that are encephalopathic and have variceal bleed, you could give them 30 ml orally every 1 to 2 hours until evacuation occurs. Then you reduce to about 15 to 45 ml per hour every 8 to 12 hours as needed to promote at least about 2 to 3 bowel motions per day. Remember, beta blockers. I've seen patients coming in acutely and they're being prescribed beta blockers. If they come in acutely and they have a variceal bleed, even if they're on beta blockers, stop the beta blockers. Beta blockers will actually worsen the situation in the acute phase. After they have actually gotten out of the variceal bleed, you can actually institute the beta blockers. So you want to do an emergency endoscopy. Like I said, it's a therapeutic, diagnostic, and even prognostic. So it should be done within 12 to 24 hours. So for the patients that are rather stable, you could give them some erythromycin about 30 minutes to an hour before the procedure. It helps empty the stomach. Then, of course, the banding can be done, and it's actually shown to reduce the bleeding in 80 to 90% of the patients, and actually reduces the risk of recurrent bleeding to around 20% in hospital. You can intubate your patients, like I said, endotracheal tube to protect the airway in some cases. In some cases, if you are waiting for a bridge, for example, you're waiting for endoscopy to get there, or you're waiting for certain drugs to be administered, or you're waiting for the patient to go for what is known as a TIPS procedure, your transjugular intrahepatic or transintrahepatic portal systemic shunt. If you're waiting for that TIPS procedure, you could actually use this as a temporal measure, what is known as a balloon tube tamponade. So there's a Minnesota or a Sangastaken Blakemore tube. So the Sangastaken Blakemore tube can actually be inserted through the esophagus. It also reaches the stomach. So it has a balloon for the stomach. It also has a balloon for the esophagus, such that you inflate this balloon and it will compress on the walls and potentially stop the bleeding as you're waiting for a definitive treatment. So it may actually provide initial control in about 60 to 90% of the cases. So it's used as a temporal measure to bridge for pharmacological therapy or endoscopic techniques, and also to bridge for example, a decompressive therapy like a TIPS procedure. So you may sometimes perform a TIPS transvenous, not transjugular, sorry. You may sometimes perform a TIPS procedure, that's your transvenous intrahepatic portal systemic shunting. Now this carries a big risk, because remember that the liver is actually important in detoxification of many things that are absorbed from the GIT. Now if you're bypassing the liver, it means that all those toxins are going to be bypassed, and there's a greater risk of them developing hepatic encephalopathy. But often we consider it in patients in about 10 to 20% of the cases where the bleeding is not controlled. You can perform an emergency TIPS procedure, what is known as emergency portal decompression with TIPS. So generally they get a stent, which is about 8 to 12 centimeters in diameter. Then they'll pass it through the liver parenchyma via a catheter. Then the wire is inserted into the jugular vein, where you now create a portosystemic shunt between the portal vein and even to the hepatic vein. It's effective in controlling the bleeding in 90% of the cases, and when it's done, in active bleeding, the mortality rates are about 40%, especially in patients who are intubated, patients who are on inotropic support, those with renal insufficiency, those with high levels of bilirubin, and those with encephalopathy. Then for your patients that now come out of the woods and you have successfully stabilized your patients, you want to perform secondary prophylaxis. So these are patients that you can schedule for banding, your endoscopic banding. So they go and tie those varices. So this reduces the risk of rebleeding to about 30%. Remember that the initial risk of rebleeding is 60%, but it's reduction to about 30%. So you can do about 2 to 6 treatment sessions of banding, which are performed within about 2 to 4 week intervals to eradicate the varices. So remember that some patients can actually go for TIPS procedure. Those that have had recurrent 2 or more episodes of variceal bleeding and have failed endoscopic and even pharmacological therapies. You have tried endoscopy with banding, you have also put them on medication, but they still have recurrent bleeding, then they can undergo TIPS procedure. But remember, there's a higher risk of hepatic encephalopathy, about 35% risk of hepatic encephalopathy with the TIPS procedure. But at 1 year, the rebleeding rates with TIPS versus those that receive endoscopy, you can see that with TIPS, it's 20%, with endoscopy is roughly about 40%. Then you also want to put them on some secondary prophylaxis in terms of certain drugs. Beta blockers are quite important. Your non-selective adrenergic beta blockers, so drugs like carvedilol, propranolol is what's commonly used, nadolol. These actually have been shown to reduce the risk of rebleeding from the varices to about 40% from 60%. So there's international consensus from the Baveno 7, which actually favors the use of carvedilol compared to the other drugs, because remember, carvedilol even has an alpha adrenergic effect, which will cause vasodilatation, and it will actually even have a greater reduction in the portal pressures. So long-term treatment with your endoscopic band ligation will reduce the incidence of bleeding to about 30%. And of course, in most of these patients, you get about 2 to 6 treatment sessions, which I already talked about, which are done about 2 to 4 weeks apart. So generally, like I said, the drugs that we're considering, carvedilol, nadolol, and even propranolol. Propranolol quite common in our setup. Carvedilol is also available in our setup here. So these ones are actually going to reduce the risk of first variceal hemorrhage in patients without any contraindications to beta blocker use. Because remember, you avoid beta blockers in acute heart failure, avoid beta blockers in asthmatic patients, avoid beta blockers in patients with bradycardia or those with heart block. Then these agents are going to be quite effective in those that have medium to large varices, or even those that have small varices with advanced liver cirrhosis. So for your patients with compensated cirrhosis, the 2022 guidelines favor the use of carvedilol for primary prevention of the variceal bleed. So generally, the doses that we can give: carvedilol 6.25 milligrams once a day, propranolol 20 milligrams orally twice a day, or long-acting, the extended release 60 milligrams once a day, or nadolol 20 to 40 milligrams once a day. So you want to gradually increase your dose through intervals of about 1 to 2 weeks, and you're aiming for the heart rate to fall by about 25%, or at least to reach about 55 to 60 beats per minute without them having significant side effects. And remember that your blood pressure must remain above 90 millimeters of mercury. Then the average dose is about 12.5 milligrams for carvedilol once a day, or long-acting propranolol about 120 milligrams per day, or nadolol 80 milligrams per day. And remember that 1/3 of your patients with cirrhosis are going to have contraindications, or are not going to be quite tolerant to beta blockers. They may have fatigue. They may also experience hypotension. So these patients are the ones that you recommend for banding, variceal ligation. So like I said, carvedilol usually is drug of choice, but we tend to also avoid it in patients with acute decompensation. Avoid beta blockers in patients with heart failure. So the prophylactic banding is preferred to the beta blockers for obvious reasons. It won't drop your BPs. It won't cause other side effects. So the banding is not recommended for those that have smaller varices because of the technical difficulty to actually even apply the band to those smaller varices. So there is a meta-analysis to end this lecture of randomized controlled trials that actually suggests that a combination of you banding the patients plus putting them on the beta blocker is actually quite superior to just the esophageal banding, variceal banding, or the beta blocker alone. So you must combine these modalities if you can to improve the mortality rates of this patient and to reduce the risk of rebleeding. I really hope you enjoyed this video on esophageal varices. If you did, consider subscribing to the channel, hit the bell notification icon so that you never miss on such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.